Hi, welcome back to the Politico Healthcare Summit. I'm Sarah Wheaton, the Chief Policy Correspondent, and we're kicking off our first panel discussion of the summit. It's on how Europe is preparing for the next health crisis. So before I kick off, you'll hear me be a broken record about this, but you can ask questions through Swapcard. Please ask them early so that I have time to incorporate them into the discussion. And as I just discussed with Emer Cook, the chief of the European Medicines Agency, we are still in the midst of the coronavirus pandemic, but we're starting to think about how to use those lessons to prepare for the next one. And so the panel now will join me for a discussion about that. Here in Brussels with me, I have Annabel Seebohm, the Secretary General of the Standing Committee of European Doctors. Annabel, nice to see you. And then I have Bart van Zyl-Langhout, the Janssen's EMEA Vaccine Alliance lead and the Netherlands campus lead. So thanks for being here as well, Bart. And then joining us online, we have Wolfgang Philipp, the acting director of HERA at DG Santé. That is, of course, the new pandemic preparation division, definitely not an agency. We'll talk a little bit more about that. And we also have Chris Fearne, the health minister of Malta. Chris, thank you for joining us.
Welcome.
Bart, I'm going to start with you. And before we look at Europe's response to this pandemic, to the next pandemic, I want to look a little bit at the global response to this one briefly. Dr. Tedros, the head of the World Health Organization, has said one of the keys to getting past this pandemic will be if vaccine developers prioritize their deliveries to COVAX, to the African Union, over wealthier countries. How's that going, and what's stopping that from happening?
Yeah, no, we fully concur. So I think this is a global challenge, and we will only be safe if everybody is safe, and that means that everybody is vaccinated and maybe even having his booster shot or her booster shot in due course. We have really developed a vaccine for the world, and precisely also because we've developed a vaccine with a one-dose regimen, it is also supremely suited also to be used also outside of, let's say, the Western world. And we are very, very committed also to supply COVAX and Gavi. And we're working very hard on that as well. We've got a very big advanced purchase agreement with COVAX Gavi that is signed, and where we already start delivering first volumes. And we are ramping that up as quickly as possible. So yeah, I can only agree that that's a topic for us of prime interest.
Mm-hmm. But I mean, our deliveries to the U.S. or to Europe, are those coming ahead of your contract for 400 million vaccines to the African Union?
They're not directly coming ahead. To some extent, we have supplied in our contract with the US. We are also, I think, very active in supplying in our contract with the EU, as we should be. But at the same time, we've already supplied very significant volumes also directly to the African Union, for instance, to South Africa. And we will also start very shortly with COVAX. So there is a little bit of a delay, but we're certainly not talking a delay of like a year. Mm-hmm. We are starting as quickly as possible. And as you are saying, we have a very big commitment for an APA also with COVAX Gavi.
Mm-hmm. Great, thank you. Wolfgang, I'm gonna go over to you. So HERA last year was pitched as being the EU's equivalent of BARDA. Is that still an apt comparison in terms of how it's actually turned out? And can you just generally help us understand what HERA is and what its ambitions are?
Thank you, Sarah. Obviously, we still think that this is the case. HERA and BARDA have a slightly different setup and also a slightly different kind of mode of operation. But at the end of the day, they have the same target, and that means to provide basically to be strong during preparedness phase in terms of ensuring the availability and the development of medical countermeasures or critical medical countermeasures that can be used in times of health emergencies, and then obviously managing that a swift and effective response happens during health emergencies. So basically, HERA has been created now as from 1st of October. HERA is an internal commission service. It's not a decentralized agency like, for example, ECDC or EMA, as I've been talking to before. HERA is an internal commission service, and HERA is becoming a very strong element that complements and strengthen the EU health security architecture. I think that is something we have learned from this pandemic, that an entity like this can add a real asset to the response capacity in the European Union. And what we are providing here is what we call an end-to-end solution. At least that is what we are working towards. Starting with an early and in-depth identification of threats, and then ensuring that appropriate medical countermeasures are available for all of us. So at the end of the day, that is basically what HERA is going to work on, and we should be fully operational. At least that's the target as from next year onwards. And then really work along the full value chain, basically from the identification of threats to the development of, to research and development of medical countermeasures, to the procurement, potential stockpiling or reservation, down to the deployment of such medical countermeasures in case of health emergencies.
Thanks, Wolfgang. Chris, from your perspective, is HERA playing an appropriate role, as far as the EU's competence in health-related matters?
Yeah, that's obviously.
It's not just a question.
Sorry, let's hear from Chris, and then Wolfgang. I'll go back to you after we hear from some folks to let you clarify a point.
Excellent. Thank you, Sarah. And I'm sure you'll come back to Wolfgang with this. But here is just part of what we would like to see develop over the next few years within the European Union. We're talking at the moment about a European Health Union, which is something which there is definite scope for. Now, member states or regional national authorities are usually somewhat jealous when it comes to competences which are already within the remit of the national member states, of the particular member states. But proving that something can be done better if we do it together can convince people to go federal. And I think when it comes to health, there is definite scope for some of the things that we do in health to be done better because we do them together. Definitely, there are some things which need to be done locally because there are so many social determinants, cultural determinants, environmental determinants of health, which means that healthcare provided in different parts of the Union needs by definition to be different. But there is something that we can do together better, and I think the pandemic has shown this. And if we manage to show that there is something we can do better together, then this should be the basis, not just of HERA, which, as Wolfgang says, is something within the Commission, but of a broader health union. And the thing that we can do better, and that we've shown, the pandemic has shown that we can do better, is with joint procurement. Now, over the years, a lot of member states have been trying to do this piecemeal. So there are the Benelux initiative, there's the Visegrad initiative, the Nordic initiative, and there's the Southern European or the Mediterranean initiative, the Valletta Declaration, which over the years has been trying to bring member states together to negotiate prices, especially for orphan drugs or for innovative drugs, together. The stumbling block has always been transparency between different authorities. I think the pandemic has shown that this works. So at the moment, it's not just vaccines that we've seen with ventilators. The EU therapeutic strategy has allowed the Commission to enter into about 200 joint procurement contracts over the period of about a year and a half. And Europe has done so well with its vaccination program because we managed to procure, to negotiate, procure, and distribute vaccines to all member states as a bloc. I think it will be a pity if we don't bring this forward. So what we've learned that we can do this together and that it is beneficial, not just because it allows access to the whole union at the same time for particular medicines, but also at a cheaper price, I believe. If we can take this forward for orphan drugs or for innovative medicines, then the pandemic would have given us something which we can take forward. And I think the Commission now has an opportunity to put this as the basis of the European Health Union and to actually set up a permanent mechanism, together, of course, with the participation of the member states, just as we've done with the vaccine procurement. So there's the standing committee with the 27 member states. And I think now is the time to have something permanent whereby on a voluntary basis, member states can go through the Commission jointly to negotiate and procure the high-end medicines, the very expensive orphan drugs, which will then make drugs not just available on paper, but available in practice across the Union. And this is possibly the basis of universal healthcare happening in real time.
Just to drill in on that, so you would be open to kind of shutting down Valletta in exchange for having the Commission take on this initiative of jointly purchasing things like rare disease drugs?
When you say Valletta, you mean the Valletta Declaration group of 11 member states, which have come together over the since the Maltese presidency, basically in 2017.
That's exactly what I mean.
Jointly.
Yes, thank you for defining that.
Sure. Yes, we would definitely be willing to sacrifice, if you like, this initiative for something which is pan-European. It will not necessarily be something obligatory, so member states can opt to negotiate separately or can go to the joint procurement mechanism. Similarly, as we've done, for instance, for ventilators. A lot of member states bought their ventilators at the beginning of the pandemic separately. Others went through the Commission, or others, like we did a hybrid model. So yes, I think there is scope for the European Commission to actually do this, because this will prove that there is a scope, there is a reason for us to have a union, a health union, because it shows definitively and concretely that doing this together is better than doing it separately. And I think that is the whole basis for having a European health union.
Can I respond to that?
Yeah, 1 second. I promise I will get to the rest of the panel, but I just want to hear Wolfgang respond to this idea of the Commission doing non-emergency orphan drug joint purchases, and as well give you the opportunity to make the other clarification you wanted to make.
Yeah, I try to be short. I mean, obviously, what Chris is saying, we know about it, and that's a call that's coming up quite often. I mean, now here we're talking, when we look at HERA, I mean, we are really looking at something we have learned during the pandemic. As it was said, acting together is much better and is much more effective. We have seen it with the vaccine strategy. We have seen it also with many joint procurements that allowed countries really to share drugs, for example, which are not there at scale, and other elements, medical devices and so on and so forth, that were not there at scale, to share them at a fair distribution level. I mean, now HERA is really focusing on providing a response mechanism for all of this in response to health emergencies. We're covering here a large panopticon already of biological threats, chemical threats, environmental threats, radiological, nuclear threats. So there is already a big area to start off with, and I think the political level needs to decide on how to continue. But I think HERA, for the time being, already has a very big portfolio of work coming up, and if that can be done to complement member states' efforts and to add on to member states' efforts, I think that would make us already much better protected for upcoming health emergencies than we were about 1.5 years ago.
Thank you. And Bart, I know you want to weigh in, but I want to bring Annabel in. Do you want to respond to this discussion about HERA's purpose and joint procurement, if you want to weigh in, or are there other key areas of what a European health union would mean from the provider perspective?
Well, HERA is one of the important elements, and we do very much welcome the initiative and the idea as such. Still, of course, I think there are quite a few open questions lingering which need to be answered and decided upon, such as governance and transparency, such as public scrutiny. We must avoid having some kind of hidden industrial policy instrument. Rather, we want to improve public health, of course. I mean, this is all in our interest. This is what we want to do. So this needs to be safeguarded and put properly into place to make sure it's running sound.
Thank you, Bart. Interesting point about industrial policy versus public health instrument. Yeah. Where do you see the line? Yeah.
Now, I briefly also wanted to respond about the joint procurement, and it's absolutely clear that during the pandemic, I think the value of collaboration at the EU level has been demonstrated, and we've of course had an advanced purchase agreement with the European Commission on behalf of all the member states, and it would have been almost impossible to negotiate that with each of the member states. And for sure, some would have had access problems and much later contracts than what we were able to do now. So I think that really worked. And in addition, the fact, of course, that we got some advanced risk-sharing payments really also helped us to ramp up our production network. So I think we are very, very satisfied with this joint procurement. But I really want to warn a little bit about seeing this as a panacea for all access problems. And I can imagine, certainly also if we're talking about orphan products or maybe certain cancer products for limited patient groups, there's very big differences between countries with regards to healthcare systems, with regards to healthcare priorities. And I could imagine that joint procurement in those cases would actually delay access compared to the unique situation that we had during the pandemic. So I also fully support what Wolfgang was actually saying, that at least the mandate for HERA, also if it comes to procurement, is really about countermeasures in a pandemic setting. I think this is where there's really proven benefit.
I think we could talk about joint procurement all day. I don't want to do that, so I'm going to give Chris one last chance to respond, and then we'll change the subject a little bit.
Thanks, Sarah. Well, you see, over the years, this has always been the debate with the pharmaceutical industry, and we've had this debate over and over. And what the pharmaceutical industry tells us is that transparency will push prices up, because then they won't be able to give secret discounts to different authorities. We've always believed the opposite. We've believed that transparency will actually bring prices down. But we could never. There wasn't enough literature. We asked the European Observatory to write a paper on this. There was very little literature. The pandemic has shown that transparency works. The only way we could negotiate and procure jointly as a whole bloc was by the 27 member states coming together in the standing committee and negotiating in full transparency jointly. And this managed to bring prices down. And I think if we're talking about universal healthcare and access to medicines, there's no doubt that pricing has to come into this. The price of new innovative medicines coming onto the market is sometimes close to $500,000 per patient per treatment there, which makes it extremely difficult to sustain across the board. So I believe the answer now, the jury is out. Transparency actually will keep and push prices down, and this will only be of benefit to patients. At the end of the day, it will also be of benefit to the pharmaceutical industry, because different from any other industry, the pharmaceutical industry has a very, very strong social dimension. And I think saving lives has at least to be as important as profits.
All right, thank you. As I said, we could talk about this all day. It's a favorite topic at Politico, but I'm gonna move on to actually a really interesting audience question from Eveline Scheres, and she is writing about the plight of kidney patients, but I think it can be broadened out to chronic disease patients in general. How can we in the next pandemic, in this pandemic, we sort of started out focusing on coronavirus, but we quickly realized that whether it's because people with the underlying conditions are more vulnerable to the coronavirus, or because people were cut off from regular care, people with chronic conditions were really facing an extra burden. And so what is happening to take that into account as we plan for the next pandemic, or what does need to be taken into account? Annabel, do you want to start with that one?
How to avoid backlogs, for example.
Yeah, make sure there are no interruptions in chronic care, get potentially vulnerable patients the extra protection they need.
I think the key word here is really capacities. So we need to have health systems which shift away from a sort of lean production, just-in-time approach to a just-in-case approach at all levels. And when I talk about capacities, I mean not only materials, PPE, medicines, medical devices, which need to be in reserve, which need to be there, but also in terms of staffing. So all this needs to be anticipated. And we, at the European Doctors, we think there should be defined minimum ratios per 100,000 population, for example, what you in fact need in terms of a crisis and what you need during normal times. So we would suggest that the European Commission defines those minimum ratios and checks on those minimum ratios and provides recommendations to member states what the benchmarks should actually be to make sure we have these capacities and to have a just-in-case approach for the future, which we don't have yet. Some are better, some are better off, some are less better off, but of course we should get to a level where capacities are there.
Wolfgang, is this a task that the Commission would take on? Would that be something HERA does or a different part of DG Santé?
I mean, that might certainly be a call on DG Santé. It is obviously not an easy task and not just about setting a benchmark or ratios. It comes really with the kind of diversity of different health systems and the structure of different health systems across the EU. But it's definitely a good point that could be looked into. Another point is obviously also to create, and that is certainly something that HERA and also other activities at EU level will look into. Let's create surge capacities to deal primarily with the effects of an emergency, in case of an emergency, and then to make sure that, let's say, the normal operations of health systems or health care are remaining operational at a level that is needed to take care of all, let's say, of all the normal business, which is not just stopping because health emergencies coming up. So surge capacities and also to have structures in place to provide for that is very important, and HERA is certainly going to look into this as well at a certain stage.
I would say, so this is really very important topic, and I think this is also a very big argument that we really need to strengthen our data infrastructure, so that we have a much better view on actually what is happening in the population, in the health of the individuals in the population, that it's now possible that we are able to track that much better, so that we're actually much earlier actually maybe discovering that there are certain groups in the population that are extra negatively affected by what is happening during the pandemic. And so having data systems, the e-patient files, which are broadly accessible, I think is a very important element, and I think there's a big role for HERA there as well.
Annabel, you wanted to make another point?
I'd just like to add one point. If you think about, suppose the Commission would issue such recommendations on minimum ratios to increase capacities, this would empower health ministries, in fact, at national level when negotiating or competing with other ministries about public funds. So it's a case for them. They can make a case with these recommendations as well. So it's really something to look into, we think.
What do you think, Chris? Would that be helpful?
Well, yeah, absolutely. And keeping the health budget at the top of the national agenda is always something we would like, and welcome any help that we can get. But there are actually two aspects to answer this question. The first is and Wolfgang mentions the surge capacity or or we call it the pandemic reserve. In other words, having excess capacity, which you can therefore have semi-dormant, just in case some natural disaster or some unexpected epidemic or pandemic or whatever comes up. And that's fine. You need to have that. It's costly, so yeah, we need a budget for that. And it can also be somewhat inefficient, because if you keep HR and human resources idle, as everybody knows, you never have enough human resources. So just keeping them idle is not efficient. But yes, we need to have, and Malta nationally is working on this. We're having what is called now a pandemic reserve, so that if something unexpected happens, we don't necessarily have to take resources away from the usual the run-of-the-mill diseases or conditions to concentrate like we did during the pandemic. But the second aspect to this question is that there are future, if you like, crises which we already know about. Climate change is one aspect, which I won't talk anymore about this, because Glasgow we'll be hearing out of Glasgow all of next week on this. But the second pandemic in the making is and then Cook mentioned this, antimicrobial resistance. It's happening. It is going to get worse. But it is very low on the public, certainly, and on possibly even our agenda. We need to bring AMR onto the agenda. It's something that we know is happening, will continue to get worse. We don't need it to become a crisis before we act. We don't need to have a reserve for when this happens, because we know it's going to happen. So I think we need to now, and Politico maybe might have a role in this as well, to bring AMR much more actively onto the agenda, both in health circles, but also within general government circles and authority circles, because we need to take this seriously now.
Mm-hmm. Yeah, I mean, does anybody have thoughts on how to get AMR higher up on the agenda? I do feel like almost every council presidency makes it part of their discussion. What's any good ideas from from the panel on how to bring it higher on the agenda? Bart, how is industry approaching this issue? It's a market problem for you.
Yeah, so it's a difficult issue, but I think AMR is still one of the topics where Johnson&Johnson is really very engaged, because we really see the threat. And I think as an organization, we also need to take responsibility. But I could definitely also see a role actually for HERA in this domain. Because one of the big let's say mandates of HERA will also be, let's say, to coordinate and to support also innovative R&D, and maybe also to create the right incentives actually for small companies, but also large ones actually to start doing research in AMR. I think that would already be extremely important. Mm-hmm.
Annabel.
We discuss AMR in particular in the context of education and training and continuous professional development for health professions, and we have an alliance together with the veterinarians, dentists and pharmacists, where we usually once a year meet in workshops to see how to better implement interdisciplinary education to avoid antimicrobial resistance, and to promote the One Health approach as environment, animal health, and human health are interlinked. And also, I think President Charles Michel just brought it on the agenda during the World Health Summit, where he addressed that One Health is something we have to focus on.
Mm-hmm. Wolfgang, role for HERA and AMR.
Yeah, I think I can only subscribe to what was said already. I mean, the Commission is addressing AMR, the problem of antimicrobial resistance, since a very, very long time through multiple policy solutions and activities, but also through a lot of research and funding through a multitude of different instruments in different areas. I mean, I totally agree with what was said. HERA is certainly going to look into it to make sure that investments are possible into research, into antimicrobials that have a future and that need to be pulled through the development phase towards becoming real products that can be used later on. So it is definitely an area that HERA is intensively looking at.
All right, we're almost out of time, so I'm going to ask one lightning round question to each of you. The same one to each of you. Yes or no? Should the EU treaties be changed to give the EU more health powers? Chris, I'll start with you.
As I say, we have to prove that there is a beneficial. There's a benefit in doing this together. Member states are extremely jealous of national competencies, and rightly so. But yes, there is scope to have a health union, a European health union. Of course, the treaties need to be changed. It has to be something which is not just a part of the administration, but it needs to actually be something which is defined in the treaties. We need to be careful not to overdo it. So we need to have a union, a health union, which is trim, but which gives us benefits rather than something which is perceived in European capitals as a monster which is going to gobble up healthcare across the European Union.
Okay, not quite lightning round. Annabel, yes or no? Want to see treaty change?
Personally, I think it's worth exploring, yes. Although my membership hasn't issued any opinion on this, but personally I think yes.
Okay, Bart?
I would say yes. So I think this pandemic has shown that the power of science is enormous, but we can only unleash it through collaboration, and I think this would help.
Thank you. Wolfgang, yes or no, treaty change?
Yes or no, I cannot say. I simply can say whatever it is. I mean, cooperation comes also with real collaboration. So that counts as working together and really finding the areas where cooperation at the EU level provides a real asset and added value. And I think HERA is one of the elements where many of these areas will be touched on and hopefully provide something in addition, apart from treaty changes or not.
All right, thanks so much. Thanks to all of you. The thing that stood out to me in this discussion is a lot of pandemic preparedness involves things that we need to do anyway, whether it's improving digital healthcare, making sure we have adequate kind of capacity as far as health professionals relative to patients, preparing to deal with antimicrobial resistance. So maybe reassuring on one hand that we can kind of keep focusing on the same things we always needed to focus on. On the other hand, well, you know, we weren't necessarily making the progress we needed to on those things before, so maybe this will be the necessary momentum. But in any case, thanks to those of you who are here with me and to the two of you who joined online. Thanks to our audience in both in person and online. And let me just make sure I'm not missing any announcements for you. The next session will be hosted by my colleague Helen Collis, who has traveled here from London to meet with all of you. It's on redefining the speed of innovation. And if you're here, you can just stay in your seats because it will be just in a few minutes. Thanks so much.